I've changed the title a bit and started with the why, who and what of a paediatrician scientist. And I just want to say that this talk is really reflecting work that my research and clinical team do, collaborators, my family, my mentors, and you know all about me. And I pleasure working across at the moment as well as Sydney. Before we go any further, really important always to acknowledge country, and I'm sure you've done that, but I'd like to acknowledge the Gadigal people of the Eora Nation on whose land we're meeting here today, and pay our respects to elders past and present, and to any Aboriginal and Torres Strait Islander people here today, and say that a lot of my work is really been informed by the great privilege of working for 10 years out at Laharoos with Aboriginal families and communities, by Aboriginal friends, Aboriginal researchers and clinicians, and I'm always very aware of the privilege that I have both as a doctor and a white person and a middle-class lady. And really, in my field, which is health equity, being really clear about using strengths-based approaches when we're addressing injustice. So for me, and it really depends, everyone has different motivators and you've got to find out yours. I'm very much a value-based kind of leader. I go off stories, and my research is very much driven by my clinical experience, and I can echo what Nick says. There is a point where you get a bit tired of the same story coming to you all the time. And you actually, for me, research is another way of treating a patient. I'm just treating a population. But what we've got in here is a life course model. And it's basically talking about the human capability that's within all of us. And I've put an amalgam of lots of children I've seen over a long 20 years of being a paediatrician. And we know that there's a whole bunch of kids not getting the life that they deserve. And so before Sam's even born, his mum has a lot of stresses and she smokes. She knows she's not supposed to smoke. It's really hard to give up smoking if you're a smoker. My husband's smoked for ages. But she's probably smoking because it's the cheapest form of mental health support you can get at the moment in terms of stress. When Sam's born, his low birth weight, we know he's going to be at increased risk of chronic morbidity and mortality as a result from the Barker hypothesis. Sam's one of those sort of rambunctious toddlers, though. He's sort of got a lot of innate strength. But because mum didn't really engage with early childhood services or antenatal services, her postnatal depression is not picked up. It's certainly compounded by the fact that she lives in a disadvantaged area. She has food insecurity. Food insecurity in Australia is basically the poor choices that people make. A lot of families have told me they don't have adequate refrigeration or stovetop in some of their housing, or they just can't afford fruit and veg. It's really expensive post-COVID. There's not been any reading at home. That might be because of mum's own literacy skills or her time or not really understanding the importance of that. Sam certainly isn't at preschool. It's actually quite hard to negotiate the preschool system, and a lot of preschools require a bond system. I'm really hoping that's going to change with Right at Beginnings initiatives. So any kind of developmental vulnerability he had around his language skills or his behaviour, which are the two big ones that get picked up. And so by the time he rocks up to school, he's going to come to me about a year later with a "can you please fix this child's learning difficulties and ADHD?" He's very difficult to manage in the classroom. He will be 18 months behind his more advanced peers. He may have started school a bit earlier too because of the issues with the preschool. He will potentially become a non-responder in terms of the clinical efficacy of some medication might try for ADHD or therapy. And that will probably be because it's hard to access therapy, or actually all the other stuff going on in his life is getting in the way. And there may be some ongoing family conflict that's stressing him out. And so we know what's going to happen. All teenagers experiment. I've got two. It's lots of fun. You've all been them more recently than I have. But he's going to fail at school. Kids who start school not really with the skills they need to flourish, that story doesn't get any better. It just gets worse. It gets worse. So he's going to fail at school. He's going to use drugs and alcohol, and he'll probably use that as a way to manage some of this trauma or some of this pain. He's likely to get depressed, and that will go on to adult morbidity and mortality, and he gets the half life rather than the full life he deserves, and that's going to be generational. I know I've depressed you, but there is kind of gets better as we go. That's my why, and I keep that why in front of my head, and that drives my clinical work, it drives my service delivery, and it drives my research. So what Sam is experiencing are multiple health inequities due to the social determinants of health. So an inequity is an inequality that is unjust, unfair, preventable, systematic, and avoidable. They cost a lot of money. So social determinants of health, for people, for a reminder, they're all the other stuff outside of health. They're things like poverty, they're things like food security, housing, transport, education, but they're also access to healthcare services. The kind kind of seen as a little bit, well, I think community peds, we're seen as a bit cringe because we work in this sort of biopsychosocial model of child health. But once you start working with children, they exist within a context and you realise how much social determinants impact on them. Not doing anything about them is incredibly expensive to the health system. It costs $14 billion a year in lost revenue, health and welfare costs because of poor health outcomes, 2.3 billion in annual hospital visits, and 5.3 million in the pharmaceutical benefits. So we do actually need to do something about health inequities. It's also, from a research point of view, really important to think about social determinants of health and how they might be driving some of your findings. So this data here is from a delightful study that I've had the privilege of. I've been doing this for 15, 16 years, research study led by Jonathan Craig with 4 chief executives of Aboriginal controlled health organisations, Great Sally Redmond from Sachs Institute, and AH and MRC. And basically, this study is the longitudinal cohort of about 2,000 Aboriginal children and their families. It was driven by the ACCHOs and the community's priorities, which I have to say it's really helpful to be doing research, really matters to people. And their concerns were about child development, ear health, housing, obesity, usual things. And we were asked to use a really quick tool to get a sense of how children were going with their development. And so I used the tool that was currently in the Blue Book that all the babies get, well, it's not anymore, but it was at that time, called the Parents Evaluation of Developmental Status. And what's nice about it, it's something you ask parents and say, are you worried about the following in your child? And we did this with all the parents coming into the study, and then we compared the data to a systematic review I'd done and to Australian and US normative data. And you can see, I think it comes up as dark brown here. That's red. This is the search data, and this data is saying these children are at high risk of developmental concerns, these children are at moderate risk, and these children are at low and low. High and moderate means you need further assessment. And the most likely concerns, it doesn't necessarily mean autism or a more really significant intellectual disability. It will be things like language delay, behaviour, things that are going to make school really hard, and that's what they were. Now, there's a couple of ways you can look at this data. First important thing about the data is 40% of Aboriginal kids were completely fine. There was no concern about their development. Really important, because that narrative I don't think very often. 60% of kids there were concerned. Now, if I just show this data, one of the risks is that people are going to go, Aboriginal kids, yet again, here's another outcome they're doing really poorly in. And they'll start to conflate Aboriginality as a risk factor. You hear that happening, and it's a very deficit model. But if I look at the social determinants of health and go, first of all, what are the drivers for these inequities? So what we've just seen there is an inequity. It's not fair that Aboriginal children have worse health outcomes than other children. So first you go, okay, well, what are the drivers? And if we look at boys who are a bit older, boys are always at high risk of pretty much everything. But we'll just look at the kids just heading into school. Who's the group who are doing the worst, if you like? And any clinician in paediatrics will already know this answer. It's those kids who have had past history of ear infections, whose parents aren't travelling very well in terms of their mental health, and have lived in 4 or more houses since birth, which is a really good measure of poor housing. That is useful because, first of all, it kind of makes the point that it's not the Aboriginality, which should never, sometimes amazingly people think that, but it's actually the social determinants that are driving that. But what's more useful is if you go, who's doing well? Just look at who's going well. It's amongst the boys again. It's those kids. Oh, sorry, and most importantly, who's not doing well. If we look at who's doing well, they're the kids who are with their parents, who have never moved housing, they're in stable housing, whose parents are travelling very well in terms of their mental health, and who've never had an ear infection. Now, ear infections often are also a measure of overcrowding as well. And so those kids have very similar developmental outcomes to any child in Australia. And to me, that strengths-based approach of what are the protective factors actually says, well, there you go, that's where we need to invest our efforts. We're going to change the school trajectories of kids, and we need to work with them. And really interestingly, this table in our publication, which took ages, can I say, publishing this, it took ages to get an international journal to kind of understand why Aboriginal child health was really important. This table caused much consternation amongst some very senior clinicians. I had one very pro and one very against. And one of the things I'll say to you, if you are a senior authorish and you've got more senior people in you, you at some point will have to make a decision that will please one of them but not the other. And you just have to go with it. But this is the table that the CEs from the Aboriginal Control Organisations really liked, because it really made sense to them in terms of the things they needed to invest in. I always ask myself, is our health system an adverse social determinant of health? And my answer is always yes. It's the thing that drives. I run a team as Director of Community Paediatrics here. I have a team of 33 staff, mainly clinicians, service providers. We have an enormous waiting list post-COVID. I spend a lot of my waking hours trying to think, how are we going to make ourselves more accessible? Because I can't feel like we are definitely a social determinant of health. This jolly man here is Tudor Hart, and he coined the inverse care law, which was published in 1972 in the Lancet. He was a GP working in Welsh mining villages. He noticed that the sickest miners who came to him and the latest and had the most stuff going on. And he had this great, very true law that continues to this day. The availability of good medical or social care tends to vary inversely with the need of the population served. If we look at some data, this is from the King's Fund. We actually look at how much does the health service contribute to people's health. We don't have Australian data on this. We'll go somewhere like America, which we all know has a very different system to us. And not surprisingly, the healthcare system contributes between, depending on what study you look at, 15% to 43% of healthcare outcomes. I'm half American. I have American relatives who are in the healthcare system. They have a very different way of viewing health, i.e. not a in somewhere like Canada, which has a universal healthcare system, much more like ours, healthcare and the way we deliver it contributes to about 25% of health outcomes, and interestingly, those other social determinants about 50%. That's really important for us to keep in our mind, particularly as clinicians and people start to attend. They probably start to think potentially because you've created a very middle class healthcare service that it's quite easy to attend, but actually it's very hard to negotiate our healthcare system. And so we always need to think about how we change things. This is just something I did in my postdoc as post-PhD. I was basically really interested in some of the really biological conditions where you see inequities in those. And so one of the most biological conditions we have is cerebral palsy. We have a great cerebral palsy alliance right here at the University of Sydney Brain Institute. And they have the Australian cerebral palsy register, which has about a lot of people can't quite remember how many children on it. And we started by understanding they want to go. And basically the question I had was, so does socioeconomic status impact on the severity of outcomes in a very biological condition like CP, where you've got a brain injury that occurs on a developing brain? And so what we did was we looked at children's health outcomes at 5 on the CP registry in terms of, and this one is, the first one is being non-ambulant. The second one is having a significant intellectual disability. And the third one's a significant comorbidity, so it's either being deaf, blind, having epilepsy, or being non-verbal. And then we divided those kids according to their socioeconomic status by their neighbourhood, which you do using census data on postcodes. And the dark blue kids live in the lowest socioeconomic groups, and the light blue kids live in the highest socioeconomic groups. And what you can see is you've got these gradients for all these outcomes, and that's called the social gradient, where basically the proportion of children with the worst outcomes comes from the lower SES groups. What's really interesting is it's graded. So the people in the middle class aren't doing as well as the people in the really high SES groups as well. And the aim is to try and flatten that gradient. And obviously countries that have much more fundamental and robust early childhood health and education systems like Scandinavia, they have much flatter gradients than we do. America has much worse ones than we do as well. And you will see a social gradient in pretty much every paediatric condition, and I imagine there's a lot in adult conditions as well. So that was the first point of call, and that was really interesting for the equity researchers I worked with. Oh, really? CP? They just didn't think that you would see this kind of thing, although all the rehab physicians I work with said, yeah, that's what I see clinically all the time. And I'm sure I'd see the same thing with autism as well and ADHD if we had a look at it. My next question was, so are we making things worse with an inverse care law? Are those kids who are most disadvantaged, who are more likely to have more severe outcomes, are they less likely to be able to access mainstream services in Australia? So I looked at data from the longitudinal study of Australian children and basically divided kids with disabilities into those who had money and those who didn't, those in the dark blue are the lowest socioeconomic group and those in the orange is everyone else. And then we just looked very simply at have you had any difficulty accessing GPs, speech pathology, paediatrician or other specialists? And apart from the speech at the age of 5, and apart from the speech pathologist, which I think is an ongoing issue for pretty much everyone, you can see, and these were significant, that if you were a low socioeconomic group with a disability, you were less likely to be able to access your paediatrician, which probably wouldn't surprise a lot of specialists in the room, but more importantly, your GP. And this is really important because GPs are kind of the foundation primary healthcare block of our healthcare system. So basically what we showed was we do have an inverse care law going on for disability. So that's my evidence, if you like, for my clinical why gut feeling. And so then you had to work out your story. And you do need to work out your story, but you don't need to work it out at your stage. You'll have an inkling, you'll develop your story over the years as you progress. But my story now is very clear to me, is to develop health service interventions that buffer against the negative impact of the social determinants of health. It's not going to win me a lot of awards. It's probably not going to get funded that often. I have got one paper that argues as part of precision medicine that if you ignore all this stuff, all your beautiful whiz-bang stuff isn't going to make the impact you want and you'll make health inequities worse. But it's what really matters to me. And it matters to the patients that I see because I deal with patients with priority populations. So that's my story. It may change a little bit as I go along, but it's pretty, to be honest, it's been pretty consistent for at least 10 years now. And I think I'm often seen, and I'm overly idealistic. I get that bleeding heart. I've been like this for a long time. And people go, it's a really nice idea, Sue, but you're completely bonkers. I'm married to an environmental scientist. He thinks the world would be much, much better if all people were gone. Yeah, because he's constantly dealing with biodiversity. It's awful going for a bush walk with him. I'll go, oh, that's lovely. And I'll go, oh, it's really. Or he'll show you the erosion on a drive down and oh, God. So, it's quite depressing. If you haven't read it, do read The Life on Our Planet, David Attenborough's witness statement to the Earth. You can watch it on Netflix also. But what it's got in it is it's got this beautiful diagram from Oxford University from a health economist. And it's the donut diagram for how you're going to address what's been going on in our climate. And let's face it, COVID, I think, was a bit of a wake-up call, as were the fires and the floods. And what you've got here is all our disasters, climate change and land conversion and biodiversity loss. And we're getting past our ecological ceiling and we probably have passed it. But the foundation to addressing a lot of our environmental changes is to address health inequities and social inequities. So I always just like to bring this up and go, this is what we need to do if we're going to change the world. So where does the clinician scientist come into it? Well, first of all, we need to do more than admire the problem. So I think it's really important to show there's a problem and to show that there's social gradients. I'm kind of now at the point of, I don't need to see any more. Really, I know they're there. What do we do about them? I think scientists just have, and it's interesting, I'm not sure if I see myself as a scientist, but scientists are great because they're kind of like, okay, how do we fix this? What are we going to do? They've got really innovative ways to think. They work with broad people. They look at something from a different angle. Clinicians get what it's like. They're there every day seeing the problem in front of them. And I think that's what we as clinician scientists do. And we need to do it fast because at the moment we've got a real delay in research translation of 17 years from an idea all the way to it actually happening in clinical practice. And that's a child's whole life. And we don't have time for that anymore. We've just got to get onto it. So that's why you need clinician scientists. We need people who are working with families and working with children, bringing their research in there and then, and also using their work to inform their research. So what can we do? I've been asking, what can I do about the social determinants of health? I can wait for a civil society. That someone suggested, this is really all dealt with by a civil society. I agree. I've just been waiting a long time for a civil society. It's not getting any more civiler. That's the word we want. So I've got to think about what I can do in the meantime. I agree with you, Nick. It's good to go big when you're going to publish. So I think often clinician scientists, clinician angle of us, we just want to publish and we don't necessarily think strategically. And working for the uni has helped me to think strategically. And we've just had a systematic review published in Paediatrics, which is a high-ranking journal for my field, that was done by an advanced trainee. She's not doing a PhD, she's just one of my advanced trainees in paediatrics with support from my clinic research team and myself and another clinician scientist, Shanti Raman, supporting her, where we said, okay, what's the evidence for if you identify and address social determinants of health in clinical practice, that it makes a difference? And God love the Americans, because they've got such an inequitable system, they have actually done a lot of work in this area. And there's quite a few randomized controlled trials in the US that look at this question. And what we have found that as long as you systematically and sensitively identify unmet social needs with your patients coming through outpatients, coming through ED, and you either give them a resource, oh, you've got a housing issue, here, have a look at this, or you give them a resource and a linker, or you train your clinicians in how to have a conversation about that, you will significantly reduce those unmet social needs within about 4 months. You may improve health outcomes, and you may actually reduce unnecessary presentations to ED. So we've just had that published, and that's been really, this is where a review is helpful. You do need to think, I've just done my investigator grant. It was a really good lesson about, gee, I should have thought about my publications 25 years ago when I was first starting. But it's really useful to be able to say, hey, we've looked at the literature. This is what we know. Nothing's been done in Australia. We don't know if it's going to work in the Australian context. And nothing's been done for children with disabilities, which is kind of my focus area. So we better do something and see if it works. And so what we've done is we are pairing with clinicians, researchers, and young people and caregivers to do the EPIC-CP program, which stands for Equity Pathways in Integrated Care for Children and Young People with Cerebral Palsy. Why cerebral palsy? Because Cerebral Palsy Alliance are fantastic and they have funding. And I was asked, after I showed that CP data by the great Nadia Badawi, so what you going to do? And I thought, well, I could look at, pathways in and how does biology and socioeconomic status mix together, but I'm not a cohort scientist. I didn't have a cohort. I'm a clinician. So I'm like, okay, well, at a coal face, we could try this sort of social prescribing idea that's taking off in the UK and is kind of done in the United States. We could see if that works. She said, right, okay, write some funding for that. And so I was funded through the Greenlight initiative, which was done by Sydney Children's Hospital Foundation with a number of philanthropists to look at this question. What's really important is the team you are with, and now with the MRFFs, you've got to have consumers on board and not in a tokenistic way. You've got to be, and that takes time. So in our team, I'm not going to go through everyone, but we are a real mix of researchers from a number of universities, clinicians, and some clinician researchers. We have Aboriginal people in our research team as well, and people with lived experience of a child with cerebral palsy or a disability in our investigator team. What makes this just the best ever grant to do and the best ever research to do is that we have 2 research advisor groups. One's a group of young people with CP, with cerebral palsy, and another is a group of parent researchers. And they're not your usual kind of North Shore, highly educated people. We've got our parent researchers include Aboriginal women from rural areas, culturally and linguistically diverse people from regional areas. Our young people include people with intellectual disability and language delay. And they are fabulous. We meet with them every month. They are co-investigators, they're co-authors on some of our papers, and they're going to be co-associate investigators on an MRFF we're going to put in. And they just save our bacon more often than not, because we started with, let's get the clinicians to ask these questions in their room about unmet needs and then give them a linker. And everyone just went, no, don't do that. That's a really bad idea. That's not what we want. We want you to do it in the way before. We got really stuck on how you ask about unmet social needs. We all got very kind of anxious that we're going to offend people. We said, do you perhaps maybe need support with this or whatever? And our young man, Matt, who's got an intellectual disability, said, stop it, not clear. Just ask them, do you need help with, and give them a picture. And that's what we did. So our vision in EPIC-CP is basically to use a co-designed social prescribing pathway to see if we can identify unmet needs in families and their kids, improve parental distress, and improve health outcomes as well. Because no one had ever done it before, we said we really do need about a year and a half of co-design, and I'm really glad. This is a really lovely diagram that my fabulous postdoc Kat has put together around how we've done our co-design. And we've done our usual qualitative interviews and a review of the evidence that everyone always does at the beginning in terms of what we need. But what we've got here, and it's just published, by the way, EPIC-CP protocol paper is published in BMJ Open. Happy to send links. But what we've got here is the clinician bit. Anyone who works clinically, this is your quality improvement cycle. Yeah. So what we did was, first of all, we said, okay, what do you need? Then we had a go at creating a pathway. Then we took it to a number of workshops and went, what do you reckon? I went, and lots of changes. Then we actually tried it in the rehab department to see if it worked. And now we finalised it. And I'd love to tell you I had all the results, but we're going to the feasibility trial on Monday. This is just some stories from families. It's been very helpful for our funders to present this evidence to them all the time. But this is what we're hearing from the service providers and the families to make sure we're on the right track. That really most clinicians would say it's really unusual to see one of those things, by that being a social determinant of health, in isolation. Usually families are affected by multiple ones. I can see why families are really overwhelmed. It's just too much. One of our research advisors told us that it took her, she spends 80% of the time on Google, and this is a lady who has lived with a child with a disability for at least 12 years, is very capable. 80% of the time on Google trying to understand our system, the social system, the disability system, and the education system. That not only takes time away from her child who's got cerebral, but her other children as well. And all the different, this is from a parent, all the different things you've got to deal with before you start dealing with your healthcare appointment. So next time a family doesn't come to clinic, it may well be because they're dealing with a housing issue, or they haven't worked out where the parking is, or they're trying to deal with their NDIS or whatever. This is our co-design. I won't take you through what we actually did. I'm happy to talk through that, but this is what we found. So this has been really helpful. I think doing that co-design is also really helpful for your ethics, because when we put in the ethics for the feasibility trial, we got all these questions going, oh, we're not sure that that's going to work. And we were able to go back and go, actually, we thought it wouldn't work either, but our research advisors and our families have told us this is what they want. So just having that co-design was really helpful. Anyway, all we did was we just went and tried our little tool in a waiting room at the rehab department at Kids Hospital Westmead. We approached 127 families and said, look, we think that addressing all this stuff that goes on in your life is really important. There are a lot of free resources out there. We've got a resource book. Here you go. Would you mind doing this for us? And amazingly, 83% of the families went, yep, that's all good. And many of them said things like, it's really good you're asking this stuff. So we had 105 families fill it in. Those who didn't were either rushing to an appointment or there was an issue with an interpreter, and we didn't have interpreter funding at that time. We do for the trial. Of the families who filled in our little really simple screening tool, 65% of them addressed at least one unmet need, and 44% addressed or at least 3 or more. And in America, the data is around 40 to 20, depending where you are. So this is much higher, but no one was surprised clinically, nor were any of the families. That's actually what we see. 76% of the families said we're really comfortable to fill this in. And the families who found it a little bit uncomfortable said, look, it's just hard talking about this stuff. The most common unmet needs, we thought NDIS was going to win by far, but actually it was government entitlement. Centrelink is really hard, followed by transport, followed by NDIS. There was not a single unmet need in our list which included housing, money, food insecurity that got a 0. Even food insecurity was at about a 20% mark. And 74% of the families said, yes, I would like someone to ring me back about this. So for our QI trial, we just had a social worker and an advanced trainee in paediatrics ring the families, take them through a resource folder that we've given them and say, oh yeah, you need to look at this or you need to look at that. And most families found that enough. It wasn't requiring a mental health or massive therapeutic intervention. And so I like to think about our community linker who will be doing this in our RCT as an EA for families or a concierge. It's not rocket science what I'm doing. In fact, that's a big, when I sort of told people about this is an idea for funding, they went, and these are people outside of health, they went, aren't people already doing that? So I'll move faster. The who, I can whiz through this. So I think it's really important. I think the luck bit's really important. So I'm from Western Australia. My parents aren't from Australia. This is my mum. She was a farm girl from Illinois, and when she was about 22, she joined the second group of the Peace Corps and went to Malaysia. This is my dad. He was an engineer. I spent a lot of my childhood at engineering sites. He was in out-of-home care from 10 when he was orphaned. He has quite a significant trauma history. He did very well. He met my mum and they moved to Australia. And I think those two were the ones who really taught me about life. Not everyone has life equal. And I knew from Dad's experience that he hadn't, and that kind of always drew me in terms of social justice. I was really lucky. Being in WA, it's a small hot. And at 17, when I was going, I definitely don't want to be an engineer. Maybe I want to do medicine. I met Fiona Stanley at one of those school, you want to be a doctor thing. And I said, I don't know. I want to be a doctor. And she said, try it for a year and see if you like it. And then Fiona stayed a mentor. Fiona, if you don't know, is the Australian of the Year, set up the Australian Research Alliance for Children and Youth pretty much ever since. This is Christine and Jeffrey. Christine is a paediatrician from Kalgoorlie. She's married to a proud Wongatha man, Jeffrey Stokes. Christine was the one who converted me to paediatrics. I was going to be a physician. I really loved. I got a prize and everything. I really liked it. But Chris was the one who just went, oh no, it's way more fun doing paediatrics. They're also the ones that taught me about country and taught me about the importance and the strengths from Aboriginal communities. Victor Nosser was great. I was about to give up paediatrics. I just had enough of seeing the same thing over and over again. I just wanted to go and change the world. I went and saw Victor in his office in South West Sydney. He was the first community paed. And he said to me, I said, oh, I just want to make a difference. And he said, that's lovely. It's great. Go and get your exam. Come back and see me afterwards. Go get your fellowship. So I did, and then I came back and actually got my first job with him. Nadia Badawi, who you don't know, is just, again, I met her in WA. She was my neonatal fellow when I was a neonatal reg, and she really showed me that what a clinician scientist looked like in real life. Craig Nellis, great Craig. Craig was my PhD coach. So I did a PhD late. My aim was to get it by 50. I know I look lots younger than that. Craig was excellent. I swim with Craig, and he basically said, no, don't do that. That paper's going to take you far too long to write. Come on, move along. So he taught me that pragmatism. And he also taught me that I could do a PhD because no one in my family had done one. I was like, I don't know. And he was very clear about doing it by publication. Really important to make sure things with your things count. And then Katrina Williams, who I will just speak to as another great mentor. And then really your team, you're as strong as your team. This is my current fabulous research team at UNSW. I'm also developing one over in Sydney. This is my fabulous Competes team. We have a lot of fun together. Have really good PhD students. This is Laurel Mimo. She's currently leading lots of research in nursing at Kids Hospital Westmead. She's fantastic. And I've got Katerina Ostrich, a wonderful young postdoc. Having them around has been really helpful. And take your work far away. Because of my parents' experience, I wanted to work overseas, so I've been in Fiji for the last 10 years. And then the kids. My poor husband probably taking the photo. I'll talk about the parent-child thing in a tick about being a woman trying to do this, but they are very grounded and think, one tells me I work too hard and the other says what I do doesn't really matter. It's all this kind of normal stuff we should be doing anyway. The journey, long, not linear or strategic, but I'm learning a lot along the way. And really, this is 2000 was when I became a paediatrician. I had probably a good 10 years, I think, in between that. So I've taken a while. Those first 10 years were faffing around, travelling and working out what I wanted to do. Then I did learning my craft as a paediatrician for about 10 years, and I had 2 babies along the way and sort of started publishing just quietly along the way. Not really sure what happened then. I think one of the kids went to school. My eldest probably had something going on. I don't know. Then I started my PhD, and you can see that's where the sort of academic trajectory starts. And I really enjoyed my PhD. I did it in 4.5 years as a part-timer. I did it when my youngest went to school. And on the 2 days that she wasn't at school, I did my PhD part-time. I got a couple of postdoc days from Cerebral Palsy Alliance for a couple of years after that. And then I got my MRC fellowship, which I did with UNSW, and I'm finishing in August. And that really changed everything. So I had 3 days a week to research, now 2 days, and combine it with my clinical work. Top tips: develop your mission statement and be prepared to adapt it. Don't make other people's goals your own. Work out what you want out of life and be flexible. Life is short. Yeah, just you get one. Do what you need to do in it. It's not about me, it's about making a difference. I think it's fair to say academic work can get kind of egocentric. Would that be? And you can meet a lot of people with big egos, and that can be quite overwhelming. So can medicine, less in peds. Whenever I felt getting stressed about, oh, I need to get money or whatever, I would just go, this isn't about me. This is about me making a difference. And that was always helpful. There's no right way. The job you want and the directions you go and change, that's fine. I didn't think I was going to be an academic when I started. Have mentors, and these change, and often they become your lifelong friends, which is really lovely. Have great PhD supervisors. Really important. People who supervise your research, good people. Network. Luck is very important, and recognising when you're being lucky is really hard, and take advantage of that. It's okay to have a career, family, and friends and other interests in your life. All are really important. You might not be able to have them all at the same time. You have to be clear on what your boundaries are and live with those. I think ambiguity is what really gets people in the end. You just have to go, well, this is how many hours I'm prepared to work in a week, or I want to have Saturdays off or whatever. You work that out for you. It will be different for every single person. And one thing around the children thing, my youngest is now going to ANU, so I'm an empty nester. I do not regret for a minute being part-time for 11 years. I do not regret going and working and doing canteen duty. I don't regret being, able to pick up the kids after school 2 days a week. For me, that's what I need to do. Other people will work full-time, and that's also fine. But do what you want to do. And also make sure you look after yourself. You do need to exercise. I swim. It's good being shouted at by a coach who says, "What are you doing? That's useless." It's actually a very good experience as a swimmer to know how bad you are at things. Try and eat well, have friends. I meditate. That helps. That's me.
Thank you so much, Professor Woolfenden. That's amazing. This is very inspiring talk. Just going out to the floor for any questions. Is anything online?
That was amazing. Thank you. Very, very inspiring. I had a question specifically about the advisory groups that you have in your research. I don't know if you've come across it, but how do you navigate like the timeline and also the potentially differing opinions in what the community wants and needs and the feasibility of it in a research space?
I think if you're driven by community priorities and they understand that you've got to do this bit first before you do the next bit, you're okay. But I think the most important thing is having people from the very beginning and explaining the idea and they help you mould that idea. Even better, they're coming in with this is what we want. I think it's really good that they push like one of our debates for our randomised control trial. People go, why don't we do an RCT? This is clearly something that's needed. So we don't have a usual control arm. What we're looking at is identifying needs in a resource folder, because we know that works as an active control, versus identifying needs in a resource folder and a link up. Now that may undo us in terms of grant funding, but none of us, particularly now we've shown a need, none of us, including our advisors, are feeling ethically okay about proceeding in another way. So you do have to give up power as both a clinician and a researcher when you work with advisory groups, but the rewards are immense.
Fantastic. Thank you again, Professor Woolfenden.